Hansen's disease or leprosy is something which is a very important topic in microbiology and has a potential to be asked as a essay question in undergraduate medical education. So we'll talk about it. This is bacilli which was discovered by Hansen in 1868. This is much before Mycobacterium tuberculosis, but we know less about Mycobacterium leprae compared to Mycobacterium tuberculosis. It's a straight or slightly curved bacilli which has the ability to form the clubbed forms or lateral buds, which is by the name Mycobacterium. If at all you do a gram staining, it is gram positive. And acid fast staining, you are going to use a decolorizer for lesser strength, that is 5%. And mainly we talk about this bacteria in two terms, that is the bacteriological index and the morphological index. This is how the bacteria looks on a acid fast staining in a high load situations. Now look at the bacilli. You have a live bacilli will appear as a solid and uniformly stained, and if it is a dead bacilli, it will appear fragmented and granular. The two main indices what we talk about, it's a bacteriological index, it's a number of bacilli in tissue, and morphological index is something where we look for only the live bacilli, so you need a uniformly stained bacilli in tissues. So this is just to represent in a diagrammatic way how it looks like a fragmented and granular appearance. Now this is generally bacilli are seen in singles or in groups when they will attach to each other by a substance called glia, which is like a lipid-like substance. Now this will, all this bacilli together will form round masses which are called the globi, and there will be parallel kind of this globi in multiple areas, so that will give a cigar bundle appearance. So this globi will appear in the virtuous lepra cells or foamy cells, which are basically histiocytes. So this is basically to show how the name cigar bundle appearance came to use. You want to grow it, there is no artificial culture media, there is no tissue culture you can use. The generation time is quite long, around 12 to 13 days for a single multiplication. For research purposes, you can maintain this bacteria and foot pad of mice. Intradermal inoculation will be done, and within 1 to 6 months period, there will be development of granuloma in that experimental animal. Now, the cell-mediated immunity of that particular animal will be suppressed using anti-lymphocyte serum. So, the clinical features or the appearance will be typically like a lepromatous leprosy. The next experimental animal is a 9-banded armadillo, which is highly susceptible, and you can see the lesions followed by generalized infection. The natural infection is seen in chimpanzees and magabe monkeys, and how much all these things are relevant to human infection is still questionable. There was a trial of tissue culture by Indian Cancer Research Institute in 1962, where they isolated the acid-fast bacilli from leprosy patients using human fetal spinal ganglion cell culture, and they tried to adapt it to grow in Lowenstein-Jensen medium. And how much of similarities are with the lepra bacilli is still uncertain. Distance-wise, it grows nicely or stays nicely in warm and humid places. If it is a little bit of moisture, it can stay up to 46 days. And if there is direct sunlight exposure, the bacilli will die within 2 hours. And if exposed to UV light, the lifespan is reduced to around 30 minutes. Now let us look at the disease itself. So you have a chronic granular inflammation that can affect any part of the body. The main areas where it affects are the skin, the peripheral nerves, and nasal mucosa. The two types of classification, the first one is the Madrid classification, where you have two extremes. The topmost one is a lepromatous leprosy, which is basically seen in people who have a lesser immunity, and the other end of the spectrum is a tuberculoid leprosy. In between, you have the indeterminate and dimorphous types. So this will depend on what is the level of immune system in that particular patient. So let us look at the lepromatous leprosy. It happens in patients with the low host resistance. So the number of bacilli are more, so globi will be also be more in number. So this is called as a multibacillary disease. So here what happens, you have superficial nodular lesions with granulation tissue, and you can see vacuolated cells. So these are the mononuclear cells, or otherwise called as a lepra cells. These nodules will slowly ulcerate, So once the skin ulcerates, there will be a secondary infection. This will slowly heal with distortion and mutilation. The bacilli will be seen in the mucosa, upper respiratory tract of the mouth and nose. They shed in large numbers in the nasal secretions. They can also be seen in the reticuloendothelial system, eyes, testes, kidneys. Slowly from there, they will be going to the bloodstream and they'll have a poor prognosis because the cell-mediated immunity is always deficient. Leprae test is negative because of the high amount of infection. They can be exaggerated humoral antibody response towards mycobacterial and other antigens. You might also see autoantibodies, and they can be biological false positive reactions with the standard test for syphilis. This is just to show how the nodular lesions look like. So, on the other end of the spectrum, you have the tubercular leprosy, which happens in patients who have a decent enough amount of resistance. So, there's a fewer skin lesions with marked demarcations will be there. There will be macular anesthetic patches. Because of the immunity, the neural involvement occurs early. So, depending on where this or which nerves are affected, can lead to deformities of the hands and feet. The number of bacilli are less, so this is called as a Paucibacillary disease. The cell-mediated immunity is pretty much adequate. Leprae test is positive because of the adequate immunity, and auto antibodies are rare here. The patient has a very good prognosis for recovery. So these are the patches, the demarcated patches of this type in a slightly dark skin individual. In between this, you have other forms, that is dimorphous leprosy, where you have characters of both lepromatous and tubercular variety. It can depend on the amount of immunity, varying immunity, or depending on the treatment, the clinical features may vary. You have the intermediate type, where there is a early unstable tissue reaction, not actually classical of any of the two ends of the spectrum. Mostly they will undergo spontaneous healing. There's also a pure neurotic type, which is bacteriologically negative, no skin lesions, and there's evidence of direct neural involvement alone. The other way of classifying is the Ridley-Joplin classification, where you have the tuberculoid TT, the borderline tuberculoid BT, borderline lepromatous, and lepromatous leprosy. Epidemiology wise, if you look at it, it's a pure human infection. How the infection happens is not very clear. Although the number of bacilli shed is quite high, it is an asymptomatic infection. It is not very highly communicable. It has a very long incubation period of 2 to 5 years, and India has a maximum prevalence of leprosy around 1/3 of the global incidence. Immunology wise, you look at it, it's a good natural immunity against the disease among our population. Only very few of the people who are exposed develop disease. It evokes both humoral as well as the cell-mediated immunity. Humoral antibodies do not kill. Only the cell-mediated immunity is capable of killing the bacilli. What is the type of disease and clinical features will depend on the amount of cell-mediated immunity in that particular patient. Lepromatous leprosy patients will develop co-infections with parasites and viruses. The tuberculin reaction, the skin reaction will revert to normal once the patient has started on treatment, but the lepromatous reaction remains negative. The lepromatous leprosy patient will have a large number of cytotoxic T cells in circulation, whereas the tuberculoid leprosy patients will have more of a CD4 cells in their circulation. Generally, this genetic predisposition is with the HLA-DR2 and HLA-DQ1. And the next most important topic of this is the Leprae reaction, which happens when you start off the treatment. So this is the Leprae reaction is also known as a type 1 reaction or reversal reaction. So when you start a patient with a borderline leprosy on treatment, the lesions will develop redness and swelling. They'll also develop pain and tenderness. The cell-mediated immunity reaction will be there, and there will be influx of lymphocytes to the lesion, because of which this pain and the erythema happens. There's a downregulating reaction which occurs in untreated or pregnant patients. Biopsy will slowly shift to lepromatous leprosy side, and this is because of the decreased cell-mediated immunity. The next reaction is erythema nodosum leprosum reaction, also known as a type 2 reaction, occurs in both borderline lepromatous and lepromatous leprosy. Usually after you start the treatment, there will be tender, inflamed subcutaneous nodules along with fever, arthralgia. The arthus type of reactions will be seen with antigens to dead leprae cells. We have the leprae test, just like we have a tuberculin test in Mycobacterium tuberculosis. So this is also an intradermal skin test. The leprament reagent is prepared from the experimental animal armadillo. It has two types of reactions, or it's a biphasic reaction. The early reaction of Fernandez, which occurs in 1 to 2 days, there will be an enzyma and induration. The late reaction of Mitsuda, which starts out 1 to 2 weeks and can last maybe up to 4 weeks. So here you will see indurated skin nodule which may ulcerate. So what is the clinical relevance of all these things? Is to classify the lesions of the leprosy patients, to assess prognosis and response to treatment, to assess resistance of individuals to leprosy, and to identify patients who can be used as the candidates for vaccine preparation of Leprabacilli. So diagnosis wise, if you see, you have typical areas from where you will take the skin smear. You can take a nasal smear, skin smear, split skin. You have typically WHO recommended sites: the skin lesions, earlobe, forehead, chin, buttocks, and forearm. Apart from that, you can take biopsy from the nodular lesions, biopsy from thickened nerves, and lymph node puncture, which can be done rarely. You do acid fast staining with a 5% decolorizer. What you see, if you see 1 to 10 bacilli in 100 fields, it's graded as 1 plus, 1 to 10 bacilli in 10 fields is 2 plus, 1 to 10 bacilli per field is 3 plus, 10 to 100 bacilli per field is 4 plus, 100 to 1000 bacilli per field is 5 plus, and more than 1000 bacilli per field with clumps and globi will grade it as 6 plus. So basically, look at the diagnostic part. You have the bacteriological index, the morphological index. Research-wise, you have the mouse foot pad inoculation, detection of antibodies to Mycobacterium leprae. Treatment-wise, Dapsone was the drug of choice. Generally, just like your Mycobacterium tuberculosis, here also multi-drug therapy is followed. So for past Paucibacillary lesions, rifampicin 600 mg once a month plus Dapsone 100 mg daily for 6 months is used, and the patient is followed up for around 4 years. If it's a multi-bacillary lesion, so rifampicin 600 mg once a month plus Dapsone 100 mg daily plus clofazimine 50 mg daily for 2 years or till the skin smears are negative. And this patient is being followed up for around 8 years. So please concentrate on this topic. Leprosy is a very important topic, and we need to learn more about this the diagnostic part, the clinical classifications part. I hope this video was short and sweet. Thanks for watching. Do like and subscribe to my channel and share the video as much as possible. Thank you.